Great. Okay, so I know we're a few minutes behind, but I think it's going to be good. So let me start while people are putting their videos on. I think we have a couple of polling questions which will be insightful. And I realize it's past midnight in some parts of the world, so not everybody's on, but failure to start poll. Okay. Can you guys see the
We
poll?
have it.
Oh, good. Okay. So I think there are two questions here. The second one's a little wordy. First one's pretty simple. Like, what percentage of your practice is in an austere environment? So that's pretty straightforward. The second one I thought would be interesting. And it's like a two-part question. We want to know, like, what would be an ideal clinical observership? Would somebody want a short-term observership in, like we were talking about earlier, South-South partnership versus North-South partnerships or observerships? And then the same thing about surgeons visiting you from another country. Assuming, let's say you're in a LMIC, would you rather have a surgeon visit you from another LMIC or from an HIC? So I think this is a good follow-up to our previous discussion with the last session. So please put some thought in it, and then let's see the responses. See a little activity there, slowing down. So, okay, so in response to the first question, so maybe should I end poll? Okay, good. Share results. Okay, so first question, what percentage of your practice? I think almost half have 0 to 25% of their practice in austere environments. And interestingly, about 30% do have the majority of their practice in an austere environment. So that's actually really nice. So you've got both the North and the South. And in the opinion, what's the most effective way of further improving your knowledge and skills? Okay, so attending webinars, very few, despite a great attendance here. Okay, short-term observerships in clinic with similar resources. So that's like a South-South visitation or observership, 25%. And 31% support a North-South observership or a South-North observership. And then the last couple, having someone visit your center, again, it's kind of split, 19% each. So how does that help us? So I'll open it up for panel discussion. Let me stop sharing. Okay, with that as a background, I think we all have so many thoughts and ideas and stories to share, but I'll just open it up and anybody can speak up or raise hands. And people who are on, please bring your video so it's more face to face. Even if you're at a golf course or in your pajamas, it's okay. All right, go ahead. So, while we have Dr. Pariyar, and I know it's past midnight for Mangal. So Mangal, thank you for being here. And I know you've been very creative in the deformity education space. And you've recently started a teaching module. And I know this is, you didn't ask for it, but I want you to tell us what have you done and how is that applicable to surgeons in low middle income countries who are interested in learning about deformities?
No, the essential thing is in terms of explaining the basics of a deformity, where you start from it's all the stuff that has been taught, which is taught otherwise, but in a kind of stepwise fashion. Number one. Number two, most important is do rather than make them do it rather than talk about it. And this is something that is that can be done very easily by for small groups also, where we've created a workbook like the Baltimore deformity course, we have our own X-rays, and then you sit and discuss things as to how a particular case can be solved. So there are line drawings, there are X-rays. Then you need to plan out that case and then work out a surgical strategy. All right, are you going to use a nail? Are you going to use a plate? And then get the participants themselves to discuss it among each other. So I found that it is the discussion more than the didactic teaching, which is important. That's number one. Number two is most of the courses or the talks that I do, many a times these are recorded, and I always request the organizers that I want a copy of whatever I'm doing in terms of a talk. I take that, I put it on YouTube. So we are all of us do so much of educational work. It takes a little time more to take that and put it onto YouTube, and then it's available for anyone who wants to look at it or search for it. So that I think is instead of talking to 20 people, I mean, you may be talking to 20 people, but it has the potential to reach 100 people a couple of years down the line. So I think that part, the use of YouTube is a very good thing rather than our own websites and stuff, because then YouTube is freely available, freely searchable. As long as you don't have some too much of graphic stuff, that can always be filtered out, or you can have a warning on that and stuff. So I found that there's a lot of I get a lot of thank yous from surgeons in various parts of the country who are in training, who've come to those videos, found them to be useful, and then that helps. And I think each of us can do that. Every talk that you do, just get it recorded and put it on.
Thank you. Colleen, did you have your hand up?
Yeah, I was just reflecting on the poll that you showed, which where it was pretty distributed in terms of how people responded to the, what's the best way that you want to learn. I think that just illustrates the fact that like everybody, right? We all learn in very different ways, and there is no right way to do this. But all of it is valuable and all of it is important. So if I, like for our fellowship in Uganda, it's great to bring people there and to teach in country. But part of what we do is also try to create opportunities for our fellows from there, our colleagues from there, to go other places and have an opportunity to be at a different hospital, to be at a different center, see how things are run there, and what they can take back to help improve their efficiency, their quality, whatever it might be at their own hospital. So I don't think there's one right answer. Just like in a high resource area, we do our work, we learn from our partners, but we also go to meetings, we go to conferences. I've learned a huge amount from my colleagues in Uganda. And so we need to all be exposed to different places. And so all of those, I think, are correct. But we want to make sure that we're fostering and facilitating all of those different opportunities for both ourselves and our partners at our primary sites, and for those of us who are working in other places, that as well.
Great, thank you. And I see Dr. Luz joined us. Thank you, Ray. We enjoyed your talk. I have another question that bothers me quite a bit. When we go to meetings deformity meetings in HICs, high-income countries, it's a small group of people who do these reconstructive surgeries. And, the undercurrent is that, well, external fixation is suboptimal when you've got internal lengthening devices. So my question is, when most of the burden of disease is in low-income countries, low middle-income countries, how can we change that paradigm? And what will it take to get the same, Scott has a great line, I don't know if it's original or not, but improvise, not compromise. I love that. So, I think with that as a principle, what are the thoughts? I know people do lengthening over nails, etc., but what's the next best thing to a magnetic or a remote motorized internal lengthening device in limited resources. Ideas? Ray, did you
Yeah,
have?
Sanjeev.
Yeah.
When we have our conferences with LRS Nigeria, we usually try to avoid showing cases with internal lengthening nails because we know that they don't have access to technology. It's too expensive. But they do have access to hexapod, external fixation. They're facile in it. And I think all of us know that you can achieve very good results with external fixators, right? That it's sometimes a harder sell to a patient, but the actual results are quite good. I'm just thinking of like a clinic I just had the other day where I was lengthening femurs in two different patients, and one had an X fix and great hip and knee motion. It had a fan across the hip, and the other one had an internal lengthening nail, was totally tight in the knee. Like it's not just the technique; it's all the care around it, and I think it's something that we're a little like, we try to purposely not show these other options because we don't want to discourage people and say, oh, this is what we can achieve, but this is something you can't. So we do try and show more of our hexapod cases so that they can be relatable.
Okay, Norgrove, please.
Yes, when we started trying to get a limb deformity program going in Uganda, when I was there using Elizarov technology, the question they posed me was, is it really, can you do this in Africa? And I said, yes, we can. But the issue is, what do you do with the patients after you've operated on them? This is a long 6-monthly or more process. And here, many of our techniques in North America have gone towards quick exit from the hospital, right? Quick discharge. You're in very briefly in your home. It's less expensive and it's better for the patient. You can't do that certainly in the environment we had in Uganda. So what we did there was establish numerous across the country small rehabilitation hostels. They were like Ronald McDonald houses. And many NGOs love to get involved in that. They're an NGO working in a certain community, and we partnered with them. Look, will you establish a little home? This is a place you can teach nutrition to the kids and social work with the families and work within that community, and it's kept within the language group of that community. And we then trained nurses and physios in that community to do the follow-up work. So these kids didn't go back to the village with an external fixator on. That was the key. We tried that in a few families that we knew we could track down and that were capable. Okay, they could go back to the village. And I think it's this aspect of care outside the hospital that's very neglected. It's neglected where I live in Canada, actually. That we can do so much more at community level if we could only think community. And it was Michael and setting this up in Uganda with a rehab center and another physiotherapist from Italy that really made the magic of our program work there, where we could introduce limb deformity correction. And in that context, the kids tolerate the fixators remarkably well. They're not as agitated about it as we are now, wanting to get out of the hospital, getting back to our kids here, wanting to get back to their schools. I think it's very doable. And my impression is it's similar in India. You have those kinds of I've done quite a lot of training and work in India, that there are many places like that where there are community solutions to how you can have a patient in the community.
Yeah, thanks. No, that's so true. I mean, again, like we've heard so much, it has to be culturally relevant and adaptable. Miguel Galban, I mean, you've had experience in South America and you do a lot of external fixation. What's your and you travel a lot to the US too, so and you're up there in terms of as a deformity surgeon. What's your take on this whole X-fix, infix, and how do you deal with patients with external fixation who are coming from everywhere?
Yeah, the most important is to be in contact with the patients. Here, I have to give my phone number to the patients. I have to be available. I mean, the patient have to reach me anytime. It's the only way to do it. I don't have a huge organization to do that. So I have to do it myself with my partners, my nurses, my hospital. But some of my patients live 6, 8 hours from here. Long distance, they have to come here. So sometimes I take Saturday to do a Zoom or maybe WhatsApp conversation with the patients to see how are they doing with external fixation. I think it's the only way to do it down here.
Yeah. Okay. Yeah. Thank you, Peter. Mayor.
Thank you, Sanjeev. Yeah, I mean, I'm in South Africa, and I think all places differ in terms of the support available. We don't use any any lengthening nails, so I basically do all deformity correction with either Hexapod or conventional Elizarov. Some of my adult colleagues have started using them, but because of the cost, it's relatively prohibitive. So one of the disadvantages of working in such a place is, lack of privacy. You've got 50 to 100 patients sitting outside your clinic, but that's also an advantage because some of these kids with severe deformities, they come there and they're sort of hopeless, and they've got somebody sitting next to them with an external fixator. And it's a much easier sell when they basically talk to each other, facilitated often by the nursing staff. And I think it's, that's sort of the opportunity to use something that's a disadvantage, but use it in your favor to have sort of a support group the patients coming to see. And I also have to give them my cell phone number, which sometimes is a problem. I have to tell them, look, please just be reasonable. Unless it's an emergency, don't contact me. But you have to do that and, make use. We've got a local clinic system and good transport, so they can come to me relatively quickly at little cost to themselves. But that's our unique situation.
Yeah. No, thanks for sharing. I don't know if Chris Jobst is available to talk or not, but I mean, Chris is a big proponent of, here's Chris. Chris, what are your thoughts on, 24/7 being on, and you've studied physician burnout. What do you think? It's the environment, it's the person, it's everything. I know I'm putting you on the spot, but I want to see what's your take on this.
My take is that we're all human beings and that we all have limits just like our patients do. And I applaud the surgeons that hand out their cell phone number and take calls 24/7 from their patients. I mean, that's remarkable. But I imagine at some point it's just can get to the point where you break down. And I'm also very close to, because I work with Dr. Bafour, I'm very close to a number of the Nigerian surgeons, and I've hosted some of them at our center, and they describe their daily workload, and I just feel for them. It's just not humane to work 7 days a week and have more than 10-hour days. It's really tough. So I think we just need to remember that we're human. We need to have a chance to recharge our own batteries, and that we can do more for our patients if we take care of ourselves first. So.
Great message. I see a message. Is there a Q&A, Jackie?
There is. I don't know if Dr. Sabatini might have, I saw her typing.
Sorry, I just answered it, but
you're allowed to, but I can broadcast it to everyone.
Please.
The question was about an initiative of the donation of struts for hexapods for low-income countries. For my personal case, it's the most expensive component.
Sanjeev, about the Hexapod, here is not practical. I mean, that's very difficult for the patients to manage Hexapod. So I prefer, when I do everything I can do with internal fixation, is going to be better. But if I have to do lengthening with external fixation, a simple Elizarov is a lot easier for them. And even for me, I mean, I'm used to use Elizarov or monolateral. It could be in some cases. So Hexapod looks very nice, but down here is very difficult.
Mangal, can I give you another point of view though? But now everybody's got smartphones, and the patient has access to talk remotely to your doctor, and the doctor has access remotely to share that info with other surgeons that are in another country. So I feel, and given that, we can actually, share struts and, assuming they're going to be cleaned and all that. So I feel in some ways it actually can help if you're in the right environment with a little bit of creativity. But I agree, good old Ilizarov is, it's time tested. Mangal, you had a question, comment? Yeah. You're muted, Mangal.
Sorry. Yeah. So two quick things. One is when I did my fellowship, it was just classical Ilizarov, and then the TSF was just coming in, right? And we learned all the basics, and it's almost like learning the alphabet, then learning the grammar, and then you can speak the language. I went back to Baltimore multiple times, and as the days progressed, as the years progressed, the fellows later on were not conversant with the use of hinges and stuff like that. So essentially, deformity correction had been, relatively speaking, dumbed down. And I agree with what I think Michael said about the use of hinges. The patient has to just turn one nut instead of 6 nuts. And I realized that if I'm going to, we've developed a 6-axis system in India now, which is cheap and we can use it. But for the patient, it's easier to turn one nut. And my fellows are forced to learn the basics of the placement of hinges, etc., etc. So what we do is we put it on a hinge, send the patients home, and then when they are more or less corrected, the fine-tuning in terms of angular correction, a little bit of translation and rotation, we put on the hexapod and then get them to do it. So I think that possibly gives us the best of both worlds.
Great discussion. Okay, so we are only, 3 minutes ahead behind. Anything else people want to say or ask or talk? Oh yeah, Norgrove has his hand up, please.
I'm not sure what Colleen said, but for the person posing the question, every time I give a talk, I say the very best donation of anything in the surgical area you could give to Africa is an external fixator, whether it be a monolateral, a TSF, an Ilizarov. They are the best thing you can give. So by all means, collect your external fixators. The biggest issue is trying to figure out how to transport them there, working it through some kind of organization or some partner where you can get it there. But yeah, please be free to donate.
Thank you. On that note, I think we'll end this session, and we do have a break. And our last session is going to be really, really interesting as well. And it's on tips and tricks. So let's come back at, I want to say 1 p.m. Pacific time. So you guys can do your math. But thank you. Thank you, everybody.